So we'll start exactly from where Sami stopped. So we'll be discussing about rational management of epilepsy, just the overviews and the general just an overview of the general principles. So over the next probably 20 to 23 minutes, we'll be discussing about right, the initiation of therapy, the anti-seizure medication. We are not using the word anti-epileptic drugs now. So try our level, will we try our level best to use the latest step. When to start, with what to start and how to start, the adding the second anti-seizure medication, stopping, and your pharmacoresistance. So this is again a history, and I think you can just sort of find out what the exact diagnosis is. It's a home video of a 14-year-old girl, and this was the first unprovoked seizure. I'll call it a seizure. It's not any other event but a seizure. So if you could describe the semiology, so I'm sure that you'll be able to describe with the information you have gathered during the past 20 minutes. Right. So that's it. What do you think? Is it a focal seizure or a generalized seizure? By definition. Bit tricky. Focal? Hands up. Right. So it's a focal seizure. And what do you think is it a motor seizure or a non-motor seizure? Obviously a motor seizure. And what sort of a motor component did you notice? The main motor component of the main seizure activity. Say it again. Probably tonic, yes. And what do you think about the awareness? Unfortunately, there is no sound card here, but the father is asking certain questions and the child can't answer. Child can't give the relevant question, the answer, and the child is kind of, dazed during that period. So probably, and went with an impaired awareness, and so and it's not falling into the GTC. So the question is, which of the following are true or false regarding the initial management of this child? So we'll be immediately starting anti-seizure medication. True or false? Hands up. So you might be, it's right. So we'll be starting or not? I need answers. If not, I'm going to probably, it's going to be rather boring, I would say. Nani? No. So yeah, he's going to wait. So let's see how it goes. Right. Wait for the second unprovoked seizure. Right. Give a therapeutic trial of anti-seizure medication to confirm epilepsy. Give short-term prophylaxis of anti-seizure medication and assess the risks of getting the second seizure. So we'll go through the answers right here. So first one is a false answer. Wait for the second unprovoked seizure, maybe yes. Give a therapeutic trial is not, no prophylaxis, and we should assess about the risks of getting another seizure. So this is the question which we discussed even before. Should we start anti-seizure medication after the first seizures? There are two ideologies or two schools of thought. So some would say to start just to prevent the physical, psychological, and the social damage, and maybe the risk of the patient going into SUDEP. And the social, of course, we have to think about play, recreation, driving, and the occupation for sure. And the other group would say, they would ask us to wait for the second seizure purely because that not all first seizures are epileptic, as we discussed, or not all events are epileptic, or possible side effects or stigma of starting anti-seizure medication. Only a minority would get a subsequent seizure. And there's a nice study which we are going to discuss that is called the first study. And I'm sure that you are thorough about this particular list. So risk of seizure recurrences following the first unprovoked seizure. This is, of course, for pediatrics, but I guess it's the same for adults as well. So they have just followed up a cohort of patients following the first seizure for a period of 30 months. And by the end of 30 months, only a minority, only about say 36%, only 1/3 got the second seizure, and 64% did not get a seizure after the first unprovoked seizure. So if we were treating, if we have started treatment, we have treating 60% of them unnecessarily. So we can hold on for a period of time. And this is the first group study which I mentioned, which is a multi-center randomized open label study where they have compared two groups: immediate treatment group, that is just after the first seizure they have started treatment, and the delayed treatment group, they have waited for the second seizure to occur, second unprovoked seizure to occur to start treatment. And they have followed up the kids, not the kids, it's a mixed group, for a period of 2 years. By the end of 2 years, by the end of 1 year and by the end of 2 years, the percentage of seizure freedom, there's no significant difference between the immediate treatment group and the delayed treatment group. Saying that the rule of thumb would be to make a confident diagnosis of epilepsy before starting on treatment, and risk of not starting or the benefits should outweigh the harms caused by the anti-seizure medication. And as we discussed, the decision should always be an individualized one. It should be tailor-made for that particular patient, that particular child, based on the general rules which we have learned. And the anti-epileptic drugs are never indicated to prevent epilepsy, not for prophylaxis, and not as a therapeutic trial, please. So we won't be giving anti-epileptic to see, we won't be giving anti-epileptics for a patient with an event. Right, now this particular patient, this girl, if you could remember the girl which we have seen in the first slide, she developed 3 more unprovoked seizures over the next 2 weeks. Should we commence treatment? Now, what do you think? Yeah, so we are going to get a green light. So if we are going to start treatment, with what are we going to start and how are we going to start? So there is this kind of, the mechanism of action of anti-seizure medication. They are diverse, but basically would base on your action potential and the synaptic transmission based on your Goodall Gannon, the physiology. So when it comes to the synaptic transmission, there are certain mediators or certain agents which could excitatory postsynaptic potentials and your inhibitory postsynaptic potentials. So glutamate action would be excitatory, sodium coming in to the cell would be excitatory, your calcium channels are going to be excitatory, whereas GABA, potassium efflux, chloride currents, and low pH would be inhibitory. So based on those, the mechanism of action, we have certain groups of medication which should act on the channel or the mediator which we have discussed. There are sodium channel inhibitors, there are calcium channel mediators, there are certain drugs which should act like GABA, there are certain glutamate inhibitors, there are certain medications like acetazolamide, that is a carbonic anhydrase inhibitor, which should change the pH of the cytosol. And there are certain other medications where we don't know what the exact mechanism of action is. And so, now we have started treatment. So we know what to be started, and what parameters or variables should we consider before selecting the anti-seizure medication on this particular patient. What do you think? What are the things that we should consider, especially in this particular era? Right. So there are anti-seizure medication specific variables starting from the seizure type or the epilepsy syndrome, the dose-dependent adverse effects, the formulations, your pharmacokinetics and dynamics, and there are certain patient-specific variables like the gender, the age, the other medication the patient is on, the comorbidities, and the anti-seizure medication availability. So that is very important when it comes to the situation in the country right now, the cost and the insurance coverage. So there are anti-seizure medication specific, patient specific, and nation specific variables. So we just discuss about the epilepsy syndromes and what anti-epileptic to be given to what syndrome. So there is this ever-growing list of anti-seizure medication, but unfortunately, there's no single drug. There's no magic bullet to cater all the epilepsy types or all the syndromes. This is the list starting from bromide in probably in 1860. Now about 17 new drugs have been approved over the past 25 years. The latest would be your parampanel, which is not new, I would say, cenobamate and cannabis or cannabidiol or CBD would be the latest. Anything else? But have we launched anything new after cenobamate and CBD? Not probably not. That's correct. Yeah, that's correct. Yeah, right. So to make our life easy, the International League Against Epilepsy have given this review article to say what drug to be given to what particular syndrome. They have listed the research, and they have given certain guidelines starting from level A to level F. Level A would be the anti-epileptic or anti-seizure medication. Sorry about that. Anti-seizure. This is from that particular era. That is why the anti-epileptic drug is still there. It should be anti-seizure medication. So anti-seizure medication established as effective as initial monotherapy, whereas F would be ineffective or with significant risk of seizure aggravation. We start from focal seizures. Again, it's not partial. It's from that particular era. I'm going to repeat that. So for focal seizures for children, it would be oxcarbazepine. Oxcarbazepine has come up because there had been a lot of studies on oxcarb, probably with more research, and the carbamazepine, phenobarbital, phenytoin, topiramate, and valproate are the drugs which you could recommend. And for generalized tonic-clonic seizures, valproate, your phenobarbital, topiramate, carbamazepine, phenytoin, and oxcarb. And mind you, certain generalized epilepsy syndromes can get aggravated by carbamazepine, phenytoin, and oxcarb, like your juvenile myoclonic epilepsy. And abscess is not a generalized tonic-clonic seizure, but a generalized seizure, your abscess epilepsy. And the childhood abscess epilepsy, we have level C evidence to start ethosuximide, valproate, and lamotrigine, and all the medications which are in red can aggravate abscess epilepsy, leading or precipitating even an abscess status. Prolandic epilepsy, again, valproate and carbamazepine, and they have mentioned about gabapentin as well, which is, of course, we hardly ever use. Juvenile myoclonic epilepsy, valproate, levetiracetam, maybe topiramate, clonazepam, and all the medications which are in red, that is carbamazepine, oxcarb, phenytoin, and maybe vigabatrin would precipitate your juvenile myoclonic epilepsy. So how are we going to start? The rule of thumb would be to start low, smile, breathe, and go slow. So be starting most of the anti-epileptic, anti-seizure medications should be started at about 10 to 15% of the planned maintenance dose. That should be the initial dose, and the doses should be increased at intervals not exceeding 5-hour half-lives. So that is very important, which is being given in the BNF, again, to make our lives easy. We need not go to the half-lives, but just keep that in mind. And the anti-seizure medication dose should be increased till the seizures stop or the serum levels reach higher supratherapeutic levels. So it's very difficult for us to get the serum levels here in Sri Lanka, but not impossible, I would say. And the daily anti-seizure medication doses should be given at intervals shorter than the half-life due to obvious reasons. And it's interesting, or it's rather practical to couple the intake or the dosing of the anti-seizure medication with some other routine daily activity, probably brushing teeth or meal time or something like that, because both the things could happen together. The patient should not only kids, all the patients should not be awakened at night to take the anti-seizure medication, which itself could precipitate an event. And variation of an hour or so in the scheduled dosing is usually not significant. And it's important to change the dose of anti-epileptic drug according to the body mass, especially in children. And drug interactions, there are certain drug interactions between the drugs or anti-seizure medications which we use, there are certain drugs which could induce the liver enzymes or hepatic enzyme inducers and hepatic enzyme inhibitors. So if you could see, your carbamazepine is a liver enzyme inducer, whereas your valproate is a liver enzyme inhibitor. So try as much as possible to avoid the combination of carbamazepine and sodium valproate. She was started on carbamazepine, and what are the possible developments with the first anti-seizure medication? So what we wanted would be an improvement, which could be an absolute remission or a resolution of disabling seizures, getting rid of disabling seizures, or continuation without changes in the presentation, or a seizure aggravation, the severity and the frequency. And she was started on carbamazepine, and her events remained the same. So why did we fail, and what to do next? So why did we fail? What do you think? What were the reasons? Anybody? No. Right, it could be a wrong diagnosis and probably the wrong choice of the anti-seizure medication. The dose might be not correct, and the aims may be unclear or unrealistic, and the compliance may not be that good. And so the next option would be, if we have sorted out the problems mentioned here, so next thing would be to add the next drug. If you could remember I'm sure that a lot of medical registrars or pediatric registrars are around, so they are thorough about their GINA guidelines or global initiative of asthma. Is something like this, is something like that. It's a stepwise approach, starting from the first monotherapy, the second monotherapy, adding on by step 3, and step 4 would be the second combination, and step 5 is definite pharmacoresistance. So you are supposed to go ahead with an alternative mode of treatment. So if we are going to add a second anti-seizure medication, if the patient is, so if the second anti-seizure medication is added when seizures are resistant to the first drug. So if the first drug is partially effective, we can continue it until reasonable levels of the new anti-seizure medication is achieved. However, if the first is not effective, so we can stop it, or we can wean it off, taper it off very soon. And single drug therapy should be the goal always, no matter, for better compliance, for less side effects, lower cost, and to avoid drug interactions. And mind you, in certain patients, certain epilepsy syndromes, the anti-seizure medication itself can induce seizures, can itself aggravate seizures. The common error what we do would be to add. We'll be adding on, but we are not going to take the culprit of the regime. And the polytherapy and synergism, there are certain drugs which you could give together, like valproate, ethosuximide, or valproate lamotrigine, for their synergistic activity. And certain drugs should be avoided to be given together, like your benzodiazepines and phenobarbitons. Both are CNS depressants, and your carbamazepine and valproate, for the reasons which I mentioned already. And it's better if you could select 2 drugs from 2 different columns for better activity, for better action. And this child was started on carbamazepine and clobazam, and she developed a painful blistering rash associated with fever and burning eye pain. What is the most likely diagnosis? I definitely need the diagnosis for this particular situation before proceeding with the rest. What is the diagnosis? Because you are supposed to know it. It's anybody? Yeah, it's most likely Steven Johnson, isn't it? So just say it again. No. Say it again. Sorry. Yeah, most likely. Yeah. So again, it's easier if you could remember this classification of the anti-seizure medication, again from International League Against Epilepsy 2010. Type A, dose-dependent side effects. Type B, idiosyncratic or immunologic side effects like Steven Johnson. Type C would be your longer-term or chronic or delayed effects. Type D would be the heterogeneity, and type E would be drug interactions. And we used to, and even probably even to date, we do routine full blood counts and liver function tests, which are not probably not necessary and probably not justifiable, because we might not see pre-symptomatic blood changes, and we might probably get a false reassurance, and definitely not cost effective to get them in a routine clinic visit. So when to consider withdrawal? We can wait for 2 to 4 years, not lesser than 2 years, probably not more than 4 years, seizure-free, event-free. And it should be an informed participatory decision where the patient, the family, the medical consultant, the previous history, everything should play here in this particular decision. And it should be a stage approach. Obviously, review the diagnosis and the past anti-seizure medication regimes. Better if you could get the serum levels as well. This is what they have said in the guideline, but we can always change it according to the facilities we have. Step 3 is to start your weaning. Start from the least beneficial, from the anti-seizure medication with most adverse effects and with the lowest serum level, one by one at a time, and should be tapered, not that we are going to take all of a sudden, and each drug should be tapered off over a period of 3 to 6 months. So it will take some time. It's not as easy as starting on polytherapy to get rid of them one by one. And timing of relapse, according to this particular study, this MRC withdrawal study from 2011, the most of the recurrences has happened within the first 1 year, while weaning off about say 70%, and majority within the initial 6 months, and after that, the risk of recurrence would be rather rare. She was trialed on multiple anti-seizure medication combinations, yet she is not event-free, and we have excluded all this what we mentioned before. So what is the diagnosis? What do you think? Where are we heading? Yeah, so it's most likely a pharmacoresistance. So no matter what, it's rather pathetic, but it's about say 50% of patients would respond to first medication given appropriately, and 1/3 would not respond to anti-epileptic, anti-seizure medication or pharmacotherapy, no matter what that we are going to give. Right, so again, the International League Against Epilepsy has defined drug resistance as failure of adequate trials of two tolerated, appropriately chosen, and used anti-seizure medication schedules as monotherapy or in combination to achieve a sustained seizure freedom or remission. But unfortunately, they haven't mentioned what this sustained seizure freedom is in their definition. So is this the end of the world, pharmacoresistant? No. So we have certain other options like brain stimulation, your vagus nerve stimulation, or deep brain stimulation, your dietary therapies like ketogenic diet, and epilepsy surgery, which could be either a resection or a disconnection. So we have started this particular program here in Sri Lanka, the vagus nerve stimulation, where we insert a small electrode into the vagus nerve with a battery inserted into the chest on the left side, and probably a seizure reduction would be the goal, not a seizure freedom. And the ketogenic diet, again, changing the dietary pattern from a starchy staple to a diet with high fats or high fatty acids would reduce the seizures to a certain extent in certain syndromes. And the mechanism of action is not very sure even to date. Right. So when it comes to epilepsy surgery, curative surgeries, either we are going to take the epileptogenic generator out, or we are going to leave the generator in, but we are going to disconnect the generator from the rest of the brain. And there are palliative surgeries like corpus callosotomy. We are going to disconnect or split the brain from the corpus callosum to reduce the number of seizures. This particular child, this is not the exact MRI of this child, but something similar. At this particular lesion, which is a cortical malformation, obviously. So we got rid of it, and the child is event-free at the moment, touch wood. And epilepsy surgery is not as easy as we think, but which is possible. In summary, make a confident diagnosis before starting on anti-seizure medication, no trials and no prophylaxis. And start anti-seizure medication according to the syndrome and add on while tapering off. Don't keep on adding. End treatment, weaning anti-seizure medication by about say 3 to 6 months per drug. And pharmacoresistance is not the end of the world. So if you're going to add, keep on adding, this would be the end. So you're going to, the child is going to be on polytherapy. The child is event-free for no quality of life. But this should be the target. I think I have about, say, 4 minutes for discussion.
Yeah. Thank you, Sanjay, for that excellent presentation on professional approach to treating epilepsy. While the physical participation get ready for questions, there are 2 questions that come up on chat box. Is it normal that a 7-month-old baby winks on and off? Could it be focal epilepsy?
Say it again.
Is it normal that a 7-month-old baby winks on and off? Right? Is it focal epilepsy?
Wings.
Yeah, I.
That, of course, we have to see the video before commenting on that. It could be a normal phenomena, or it could be abnormal, depending on what the definition of this particular winging. So it's better if you could send a video or go to the closest pediatrician.
Okay, thanks. There's another question. I think the answer might be in, is there a classification of epilepsy in children, typical versus atypical, based on duration of onset of fear? What is the significance?
Okay, so we take that because I normally discuss it as so the febrile seizures are classified as 3 types. We simple febrile seizures, complex febrile seizures, and within the complex, if they are lasting for more than 30 minutes, it goes as febrile stages. So that's the one that we use. We don't use typical and atypical. So it's simple febrile seizures, complex febrile seizures, into the complex group, or the febrile status epilepticus.
Is there any questions from the audience?
Audience?
Questions, because that was exactly very good, lot of principles in that presentation. So do you have any questions to ask before we move on to the next question? Any from the audience?
And to add, so you guys are going to be consultants, pediatricians, probably general physicians, or neurologists, to start pharmacotherapy and to refer to a center, to a coronary center for more than pharmacotherapy. So don't wait. So we have all the facilities, so utilize them as much as possible.